Okay, let's begin. On behalf of the Mount Sinai Health System, I want to thank each and every one of you for being with us here today. It's hard to imagine that over a year ago, our institution became the epicenter of the COVID-19 crisis, a defining moment that we will never forget. On one day, we had over 2,200 patients in our 8 hospitals with COVID. I'm so proud of the immense collaboration and unity of our staff on the front lines and of our brilliant scientists who changed the course of science through their diagnostic tests. I also want to express my sincere gratitude to our trustees and our donors who rallied behind our health system like never before. You are an integral part of the Mount Sinai family, and your ongoing support demonstrates your leadership as well as your deep commitment to our vision of redefining what is possible in terms of how we deliver best-in-class and compassionate healthcare to the diverse patients that we serve. Today, I'm honored to welcome Dr. Scott Gottlieb to join me in discussing how COVID-19 is defining our new normal and what the future holds. Scott serves the Mount Sinai Board of Trustees, and he graduated from the Icahn School of Medicine in 1999. He's also the former commissioner of the FDA, a fellow of the American Enterprise Institute, and now serves on the board of directors at Pfizer and Illumina. Thank you, Scott, for joining us today. So now let's get started. I have a number of questions for you. Let's begin with your overview. Where do you think we are in the course of the pandemic, both on a national and a global scale?
Well, thanks for having me, Ken. It's a great honor to be here. Also a graduate of Mount Sinai's residency program in internal medicine, in addition to the medical school, as you recall. First on the U.S., I think the situation in the U.S. and globally are different, obviously. In the U.S., I think that we're in a very good position right now. I think we're going to see cases really start to collapse over the next 2 or 3 weeks as we head through May and stay at low levels through the summer. And the reason is multifold. First of all, we have a lot of population level immunity at this point. If you think about the number of people who've been vaccinated combined with the number of people who've been infected with the virus and have some level of immunity from prior infection, we're probably approaching 210 million Americans. There's been over 140 million Americans who have at least 1 dose of the vaccine, and probably about 130 to 135 million who've been infected. And even if you assume about 30% of those who've been vaccinated have been previously infected with COVID, which is probably a pretty high estimate, because probably a lot of the people who've been vaccinated, a higher percentage of people who've been vaccinated have not been infected relative to the general population, because a lot of people, older individuals in particular, were taking active steps to avoid infection. But even if you assume that the rate of infection among the vaccinated population was proportional to the overall rate of infection in the general population, you're getting to 205 to 210 million Americans with some level of immunity, either from prior infection or through vaccination. And all the studies that we've seen, including a lot of research that's come out of Mount Sinai, which has been pioneering a lot of this work, have affirmed that prior infection and the vaccines afford a high level of protection from reinfection. We have not seen reinfections happening on a wholesale basis, and we haven't seen people getting infected after vaccination on a widespread basis. It happens, and it certainly is reported, and there have been cases of people getting reinfected, but it's not happening on a widespread basis. And even the new variants don't seem to pierce the prior immunity, at least for now. So, when you're talking about 210 million Americans with some level of immunity, that's a pretty big backstop. You combine that with the fact that we're entering the summer. Coronaviruses typically don't circulate in the summer. They're typically late winter pathogens. So we're going to get a seasonal backstop against continued spread. And people are still being cautious. I think even after public health measures are lifted, I think the consumer behavior is going to be different. I think people are going to behave differently in terms of how they approach respiratory diseases more generally. You combine all those factors, and I think you're going to see a real collapse in cases. And you're seeing that downward trajectory right now. I think it's going to accelerate in the next couple of weeks. We're sort of hitting a critical mass of vaccination right now. In terms of the global picture, obviously it's more mixed. You're seeing devastation in India. Also Thailand, you're seeing rising cases. Indonesia looks like it's at risk. And what seems to be happening, at least in part, is that while the first wave of infection with the sort of old variant of coronavirus seemed to hit hardest Western societies that couldn't implement good respiratory precautions, and industrialized nations where you had dense population centers, and more rural countries with more rural areas, less densely populated cities, seem to have been spared in the first wave. Now you're seeing those countries succumb to the infection quite considerably. And that could be a function of B117, that the first wave, which obviously was with the wild type variant, didn't really affect certain nations. B117 is sufficiently contagious that no country is being spared. And you're seeing now large outbreaks in countries like Thailand. So I think it's a different picture with B117 globally. And a lot of nations that might not have been at risk as much during the first wave now seem to be a disproportionate risk from B117. As far as India goes, there is some evidence that they're starting to peak in terms of their daily infections. It's hard to tell for sure because their testing isn't stable. So you can't use cases alone as a really reliable measure, but there's some indication that they're starting to peak. And that would sort of make sense if you look at the seroprevalence studies that have been done in India, the studies looking at antibody levels to try to gauge how many people have been exposed to the virus. Those studies showed that in December and January, about 40% of the population in their largest cities had been already exposed to coronavirus, which is pretty high. And now they've obviously had a very dense epidemic since the beginning of the year. So you would expect that maybe upwards of 60% of people at this point have some level of immunity, mostly from prior infection, but also from vaccination. They have vaccinated about 10% of their public. And so the combination probably is going to lead to a point where they start to tip over as well, and we start to see cases come down in India.
Okay, so you told us that 210 million Americans, you estimate, will either be vaccinated or will have been exposed to the virus. A lot of people have heard the term herd immunity, and they see something like 70 to 80% of people need to have either been vaccinated or exposed, which in the United States would put us something more than 210 million. Tell us, when do you think herd immunity really happens? Is it a hard and fast rule about 70, 80%? What do we know in the past from influenza and other viruses when you really do get herd immunity? Just give us some sense of what that means.
Yeah, I don't think we ever really get true herd immunity against coronavirus in the way we have herd immunity against measles or smallpox or polio, and those viruses don't circulate because, in those situations, you're dealing with viruses where the viruses don't undergo rapid mutation. So you're able to vaccinate, and the vaccine provides durable immunity. And we also mandate vaccines in children. And so you're able to achieve a high level of population-wide immunity by just vaccinating children and instilling in them durable immunity. Here, you're going to have a situation where we're not going to mandate the vaccine. So we might not get above, my guess is by the fall, we'll get 200 million Americans vaccinated for coronavirus between children and adults. And I'll sort of unpack that in a little bit. So we might never get above 200 million Americans by sort of the start of the school year. And I think that's going to be ambitious. You're going to have declining immunity over time here, either from people who've been previously infected and people who've been vaccinated. So the vaccine's not going to provide durable immunity. And you're going to get new variants that are going to at least partially pierce prior immunity from either vaccination or prior infection. So it's just not going to be sustained. So it's unlikely that we get true herd immunity where this just stops circulating. I think we do get to a point where this stops circulating at anything near the levels that we've experienced over the last year. And we get back to some semblance of normalcy, probably with an added layer of precaution in our lives and how we work. I think we're not going to be as complacent about respiratory pathogens in the winter as we've been in the past. We've let far too many people become infected from flu and RSV. It was always, seen as something noble to go to work and brave out a cold. I think things like that are going to be frowned upon, and you're going to see more people wearing masks in sort of public transportation and public settings like that. I think people are going to be more aware of the risks of respiratory disease in the wintertime. That's probably a good thing. I mean, we'll probably pick up a lot of productivity improvement, a lot of reduced death and disease from things like influenza just by having a marginal layer of added protection in society. But in terms of where we get with coronavirus, my guess is that over the summer, we never get that much below 10,000 cases a day. I think there'll probably be days where we record 5,000 cases, maybe a little bit less than that. Maybe the 7-day average as we get into sort of July and August, that the sort of lows will be, 5,000 to 7,000 cases a day. But we're going to be picking up cases. We're doing a lot of testing. There's a lot of point of care testing and at-home testing now. And even though that's not getting picked up, it's not getting reported as negative tests, when people have positive tests on those at-home tests, they do reflex to a definitive lab-based test like a PCR test, and that does get picked up. So we're going to be picking up cases. We're going to have outbreaks in camp that are going to get picked up. We're picking up a lot of asymptomatic and mildly symptomatic infections. So I don't know that we get to a point where, you know, we're much below 5,000 cases, and we might bounce around 10,000 cases for a while. And we need to recognize that's probably what victory against the virus is going to look like. And that's not a bad thing. It's not a bad thing that we're doing a lot of testing and picking up all these mild cases, because we can get people isolated. We can trace their sick contacts and try to prevent larger outbreaks that way. I think the way we need to start thinking about coronavirus is the overall vulnerability of the population and how vulnerable is the population. And on that measure, we've dramatically reduced the vulnerability of the population through vaccination, and we're going to continue to reduce the vulnerability of the population through continued vaccination. In terms of where we are with vaccination, and I've long felt this, so I've been saying this for a while, that we would run out of demand before we ran out of supply, and this would be wide open in April. You and I had this discussion. I think that we're at 140 million people who have at least one dose right now. We're doing pretty well actually getting people back for the second dose. The recent reporting was that 8% of people aren't coming back. That's actually a low percentage when you think about things like Shingrix, the other 2-dose vaccine, where you lose more people to follow up. But I would suspect that we'll start to dip down to maybe 500,000 people vaccinated a day. It's going to be hard to continue to vaccinate 1 million new people a day. You know, the numbers might look like 2 million a day because we're bringing people back for their second dose. But when you look at the number of people who've actually been vaccinated for the first time, it's going to dip below 1 million pretty soon. But that's not bad. You know, so if we can vaccinate 500,000 people a day on average for the next couple of months, you know, we get to maybe 160, 170 million people vaccinated, adults vaccinated. I think once the 12 to 15 gets approved, so there's 17 million kids between the age of 12 and 15 in this country. Once that gets approved, I would guess we'll pick up about 5 million right away. That's what some of the estimates show.
So let me turn to a slightly different question, which is about the variants, and speak a little bit like a scientist. What's very unusual about COVID now is that we're getting so many people affected, that there's so much transmission, that it increases the likelihood of mutation. So even though coronavirus previously didn't mutate that much, not like influenza, when it transmits this frequently, it mutates. And it can mutate in the spike protein, which, for those who don't know what I'm talking about, is where your vaccine is directed against. So what do you see as, you know, a MD clinician who's very sensitive to all this, about the likelihood that we could come up with a variant here that is really going to change the outlook and make our optimistic view far more pessimistic for what 2022 might look like, or even the end of 2021? That instead of just a more transmissible virus, we're going to have a virus that isn't responsive to our vaccine.
Yeah, well, look, you don't know what you don't know, but what a lot of the folks who do this, including some of the researchers at Mount Sinai, Trevor Bedford at the Hutch, the folks out of Scripps, Anderson out of Scripps, what the growing sort of view is, and I wouldn't say this is a consensus yet, this is just speculation, is that this virus has mutated very rapidly over a short period of time. It's mutating at the rate of influenza B right now. But it's probably mutated very quickly over a short period of time and reached a new fitness level, and it's unlikely to continue to mutate as quickly. And it's probably shown us a good portion of the repertoire of how it's going to mutate. We've probably seen, there's still things we don't know, there's still things it's going to do to try to evade our immunity, but it's probably done a lot of the things that it's capable of doing. Because remember, in order to evade our immunity, it has to mutate the spike protein. That's the protein on its surface that it uses to gain entry into our cells. And that's basically what's in the vaccines. The Pfizer and Moderna vaccine are genetic sequences of genomic material, mRNA in this case, that code for production of that spike protein. So by giving people a genomic sequence of the RNA that codes for production of the spike protein, basically they start to develop that spike protein in their bodies. They become a manufacturing plant for the protein, and then they develop antibodies against it. If the virus wants to evade our immunity, it's got to mutate that spike protein in a way that our immune system, our antibodies won't recognize it anymore. But that's a critical protein. Remember, that's the protein it uses to gain entry into our cells. So if it mutates it too much, maybe it's not going to be as effective at gaining entry into our cells. So it's walking a very fine line between trying to change that protein enough so it can evade our antibodies, but not changing it so much that it can no longer be functional in trying to latch onto our cells and gain entry into them. And so there might be a limited repertoire of what it's capable of doing that's still going to be making an effective virus. Now, that said, we talk about strains. We talk about the South Africa strain, the Brazilian strain, the New York strain, New York variant, the Indian variant now, B117, which is from UK. Really what we're looking at is mutations. These different strains have different mutations in them. And there's a handful of mutations that worry us a lot. In the South African, the Brazilian variant, it's this 484K mutation. It's a key mutation right on that spike protein. It is possible that you could see variants emerge that combine some of the mutations we've already seen in new ways that create viruses with very different characteristics. Sometimes in virology, 1 + 1 doesn't equal 2. You could take a mutation that isn't so bad in one strain and another mutation that isn't so bad in a second strain, and you put them together in a novel strain, and all of a sudden the virus behaves much differently. So it's a process called epistasis in virology. And that's in fact maybe what happened in India. India has this new variant, this new strain 617 that you've probably heard about. That 617 has 2 mutations in it that concern us. One that we found in the Los Angeles variant, and one that we found in the South African variant, the 484K mutation. So it combines 2 mutations that were in different strains in a very novel variant, and it seems to be behaving differently in India. We think that's partially responsible for the epidemic they're seeing. So,
but do you think that those variants have made the vaccine less effective in India?
So far, the evidence is no, at least with the mRNA vaccines. We see some degradation in you don't have great experimental evidence. There is some experimental evidence right now. So Pfizer, for example, has data out of their trial in South Africa where they didn't see anyone who is vaccinated get infected with the 1351 strain. Small data set, but it's definitely encouraging. Some of the best data comes out of the experimental evidence where you're looking at in laboratories the ability of the antibodies produced by the vaccine to neutralize these new variants. And you guys are doing some of that work in Mount Sinai. And so far, you haven't seen any variant that where the sort of protection afforded by the vaccine just falls off a cliff. The vaccines are protected against 1526, 1351, B117. So far, we haven't lost the vaccines. And I think that that's a pretty good indication that we're probably going to be able to maintain them.
That's great. So a lot of the people here have heard that the CDC has been a little less restrictive, encouraging us, maybe we're not discouraging us from being outside. Tell us what you're doing. You've been vaccinated. Where do you go to restaurants? Do you wear a mask? When you go outside, do you wear a mask? Tell us what we should do about masks and restaurants and outdoor gatherings and indoor gatherings, not from the CDC's perspective, but your perspective.
Yeah, well, look, I still follow Connecticut public health ordinances. So I'm still listening to Governor Lamont. And Lamont told me I have to wear a mask until mid-May. And I'm wearing a mask when I'm out in public. I think that when you're vaccinated in a low prevalence environment, especially outdoors, you needn't worry. I think the risks are extremely low. And I don't think that we should be erecting public health measures to try to mitigate very low risks. The public health measures really should be geared towards trying to prevent introduction of the infection in vulnerable settings, so nursing homes, daycare centers, and also prevent large outbreaks, prevent a situation where you have a single introduction that could lead to a lot of infections. We shouldn't have public health measures that try to prevent a single individual unknowingly infecting another single individual. We're not going to be able to prevent that, and we shouldn't really try. And that's really what I think CDC is sort of stuck on right now in holding on to some of these public health measures. In terms of practical advice, I think when you're in a location where prevalence is low, and I'll give an example of that, when you're in an outdoor setting, particularly, I think you could feel comfortable being mask free. I think when you're in an indoor setting with a largely vaccinated population, in a low prevalence environment, that's also another environment where you can feel relatively safe. Where I still would be cautious is when I'm in a mixed environment with a lot of people who I don't know. Indoors where there's poor air circulation, I would still wear a mask in that setting right now. And I'm probably going to wear it for a period of time. When I travel, things like that, I'll probably keep a mask on even through the summer when prevalence is low and I'm vaccinated. So an example, San Francisco, 68% of the people in San Francisco are now vaccinated for COVID. They're recording about 30 infections a day, and they have pretty good testing in place. There's about 20 people hospitalized across the entire city. That's a city where you can go out and feel comfortable doing things. And in fact, Bob Wachter, the head of medicine at UCSF, tweeted out a photo of himself resuming his normal poker game in his basement, which I'm quite sure does not have good air circulation, with a group of about 10 other guys, because they're all vaccinated.
So are you going to outdoor restaurants?
I'm eating outdoors. I think that it's going to take a lot to get me back inside a restaurant in the summertime. I would have preferred to be outside anyway. So
right, but you would.
I'm back. I've been eating out. In fact, I ate out in the wintertime too, under heating lamps with a blanket on me. But I would only go outside.
Okay, so we're talking about booster shots. Do you tell us the timeline for when you think booster shots will be available, and tell us what you think they're going to do? Yeah. What will they accomplish?
So I think, this is me speculating. It's not me wearing my Pfizer hat. I think that there's going to be a recommendation from CDC, from ACIP, which is the Vaccine Advisory Committee of CDC, sometime, that's going to say something to the effect of, and this is just speculation, but I'm just trying to lay out the general contours. It's going to say, if you're 50 years or older and you're more than 6 months out from finishing your vaccine schedule, or maybe it's 8 months out or 10 months out, probably a little longer, maybe 8 or 10 months, then you should get a booster shot at some point in the fall. I think we're going to end up there. And the reason we're going to end up there is because what we've seen in the data now, both post-vaccination but post-infection, is a degradation in the protection afforded by either vaccination or prior infection. So you've seen that now in the 6-month follow-up data with the vaccines. The vaccines are still very protective, 80% protective overall at 6 months, but that's at 6 months, that includes people who were vaccinated 2 months ago, 4 months ago, and 6 months ago. And so it's 80% overall. So you could surmise 90% overall. But you could surmise from that the 6 month group is below 90%, and the people who are 2 months out are above 90%, because the vaccines are about 95% effective. So you're seeing a degradation. The degradation is probably stronger in older individuals. And the reason why we surmise that is that the best study so far is the Danish landmark study, which looked at a very large population of people post-infection, what level of immunity they had post-infection. And around 7 to 8 months, the general population overall had about 80% protection from reinfection at 7 or 8 months. But those over the age of 65, it was only 47%. So you saw a pretty sharp decline in older individuals in terms of their protection against coronavirus from their prior infection. And you could surmise, while the vaccine induces a level of immunity that's stronger than natural infection, so you're getting a more robust immune response from the vaccine and more protection than if you were infected with coronavirus, you could surmise that there's going to be degradation with the vaccine as well. So if the goal is to maintain people above 50% protection through the entire coronavirus season, you're not going to want to take a 65-year-old individual who was vaccinated last December or January and let them go into the winter of 2021, 2022 with a vaccine that's 12 months old, knowing there's a degradation, because there's a likelihood they're going to fall below 50% protection with a vaccine that's slowly degrading over time in terms of the immune protection it affords. Now, final point, as you know, what we're talking about here is immunity from infection. It's likely the case that the vaccines are inducing a large complement of immune cells. Some protect you from infection, others will protect you from disease. And so even someone who's 12 months out from their vaccine, while they might have a higher likelihood of getting infected, hopefully the vaccine still is inducing immune cells, T cells, and memory B cells that are going to protect them from getting really sick if they do get infected.
Right. So will this booster help us with the variants as well? Or is it going to be a booster for really what was the original virus?
Yeah. So that it's a great question, and the answer is we don't know what we're going to use yet. So both Pfizer and Moderna are developing boosters that are targeted to 1351, which is the South African variant, and they can put other boosters in production. It's sort of plug and play. That's the beauty of the mRNA platform. You don't have to figure out how to grow the virus in a cell culture and how to cleave off its proteins and go through a 6-month complicated process. You basically plug in a new cassette of mRNA and you start churning out different mRNA. The decision we need to make from a public health standpoint is, are we going to boost people with the existing vaccine, or are we going to boost them with, let's say, a new vaccine that's targeted to the South African variant, figuring that the South African variant might be more likely to become epidemic here, and the existing vaccine shows a little bit of a decline in effectiveness against that variant. It's a hard question because even if you know that or you believe that the 1351 vaccine is going to protect better against 1351, you don't know if a vaccine targeted to 1351 is going to protect better against 1526 and P1 and 617 and 117. You're not going to know. We do know that the existing vaccine works pretty well against everything. And so, there's going to be, I think, from a public health standpoint, it should be a bias towards using what you know. If what you know isn't so bad, then rolling the dice on something that you have less experience with. Now, that said, the presumption is going to be that if you're boosting someone with a new vaccine, they're going to have some residual protection from the old vaccine. So maybe you can get the best of both worlds. You still have some of that residual protection, and now you're boosting them with something that's targeted to 1351. But I think that all else being equal, probably the bias is going to be to use what you know rather than what you don't know. Now, that said, we'll have the 1351 available. And from a manufacturing standpoint, Pfizer can literally just plug in a cassette and start churning out whatever their monthly run rate is. If they're able to do 60 million vaccines a month or 70 million at that point or more, they can just start churning out 1351 vaccine if we need it. So they'll probably produce a certain amount, the companies, they'll stockpile it. And even if they don't use the 1351 booster, if they boost with the existing vaccines, we'll have it there if we need it.
So if you originally got the Pfizer vaccine, do you have to get boosted with a Pfizer? If you got Moderna, do you have to boost it with Moderna? And when Johnson & Johnson is here, where they're going to need a booster too, should you stick with Johnson & Johnson? Tell us, with all the vaccines that are going to be out there, whether you can cross-vaccine.
Yeah, so I have to take my Pfizer hat off and my former FDA commissioner hat off because none of this is in the vaccine label. And I think at best what we'll have in the label in the fall is some safety information on people who cross over. There's some studies underway looking at the safety issues, and there's been people who inadvertently crossed over and they're being followed. The bottom line is it shouldn't matter. I mean, you should be able to cross over one vaccine to the other. I think we need to develop enough data to give people comfort around that question, because if we tell people you can only get the vaccine you have, it's going to make it harder to revaccinate the public. People are going to have to make appointments at the place that's giving the vaccine that they had. So you want to have an environment where people can freely cross over. So the mRNA vaccines should be relatively interchangeable. I wouldn't be worried if I inadvertently took one vaccine and then took another one as a second dose. With the with the vaccines, the viral vector vaccines, so the J&J vaccine, they're different platforms. Obviously, China is actually looking to do this on a wholesale basis, where they look like they're going to be giving their protein-based vaccine, and then they're going to give an mRNA vaccine booster after the protein-based vaccine. There is going to be some data. There's some studies underway looking at giving a dose of Johnson & Johnson vaccine and boosting with mRNA. So we'll have some safety information. The bottom line is it should be fine. There's no reason to believe there's going to be untoward safety issues, but we don't know until we have the data. And in a way, you could postulate that maybe you're getting the best of both worlds in that scenario, because the viral vector vaccine is probably inducing more of a T cell response. And then the mRNA vaccine is inducing a very robust antibody response. And so you could be stimulating different arms of the immune system with the two different platforms.
Okay, so putting on your FDA hat back, and you watch what happened to Johnson & Johnson and the pause. There's been a lot written about that. Whether they should have paused, what that is going to contribute to more vaccine hesitancy. Did they do the right thing?
There were two things that they could have done. One was to pause it. One was to put out a strong public health warning. I think that there would have been some negative reaction from both of them. What they were doing, what they wanted to do, was make sure that they get awareness among doctors to be looking for these events and to aggregate whatever events have occurred. And the reason they paused it is because they weren't sure what the rate of these side effects were going to be, and they didn't want other people to be harmed while they were collecting this data. And the reason why they were particularly concerned about it is because with the J&J vaccine, it was right at the moment when supply of that vaccine was really ramping up. So a lot of people had been vaccinated very recently. So if those people were going to develop this side effect, they didn't know it yet. And so they were in a situation where they were worried that all of a sudden there would be an explosion in these cases, and they'd be continuing to vaccinate new people while these cases are accruing. And before they know it, in a week, they would find that there's not 6 cases, but there's 40 cases. So, one of the principles is, if you think something's causing a harm, don't continue to induce the harm. And the place where this became most operative is on the food side of FDA's house. I used to have to contemplate this all the time, because we would find out, 2 days before Thanksgiving in 2018, we found out there was E. coli in spinach. But what we determined was that the spinach that had the E. coli in it that was making people sick was still on the market. Usually by the time you find out about a pathogen in a food product, it's long gone. The food product's been consumed, and you're finding out after the fact. It's very rare that you actually spot an outbreak while the product's still in commerce. So what we do, we withdrew all the spinach from the market 2 days before Thanksgiving. I mean, it was a major action by FDA to do that at that time of the year. But the reason was because we knew spinach was still on the shelves that was contaminated with E. coli, and we knew we had the opportunity to prevent more people from being harmed. That's how they would think about this vaccine. So did they do the right thing? I think they took a reasonable step there. In terms of hesitancy, I'll just touch on this briefly. I think we need to be sort of careful how we view people who haven't been vaccinated yet. Some of them are hesitant about the vaccine, for reasonable reasons. It's a new vaccine. I've never taken it before. My friend had a reaction to it, so it makes me a little nervous. All reasonable concerns that a patient would have, and we need to counsel them through that. Some people want to get the vaccine. They're not hesitant, but it's inconvenient for them. It's hard for them to get. They work all day. They take care of a family all night. For them, you need 24/7 pop-up sites that promise no wait time. You need to make it really convenient and easy to get the vaccine. And some people are just marginal customers. We're getting into marginal customers now. The people who really wanted it have been vaccinated, the ones who lined up. And now you're getting a lot of people who say, I'll get the vaccine when I'll get the vaccine. I'm not really that anxious to get it. And so for them, you need to present the vaccine in an environment, and hopefully through an intermediary that they trust. It needs to be really easy. So Walmart announcing on the loudspeaker, free COVID vaccines right now, no wait. That's really good. Stores, pharmacies are starting to do that. That's how you get the marginal customers. So we talk about the people who are unvaccinated as vaccine hesitant. Not all of them are hesitant. It's softer demand. And if you have softer demand, you need to market it better.
Okay. So tell us about children. When do you think we're going to be able to start vaccinating children? How young can we go? And isn't that critical to getting herd immunity, that we really can start to vaccinate all these children?
Yeah, the children are going to continue to be a vector for the virus. And until we get them vaccinated, we're going to continue to have circulation of the virus. What the data in Israel shows is that once you get a high percentage of the adults vaccinated, you don't see infection in the kids, or you don't see outbreaks in the kids, because the adults are giving it to the kids and the kids are becoming vectors. And so if we can get a good percentage of the adult population vaccinated, if the Israeli experiences any proxy, we'll see a break off and change of transmission in kids as well. But the Michigan experience is instructive. And part of what contributed to Michigan's very dense epidemic was they reopened their schools. They reopened their schools right against the backdrop of an outbreak of B117. And the schools did become focal points of spread. Schools are not inherently safe. I think they can be made more safe, and you can open schools against the backdrop of COVID spread, but they're not inherently safe environments. In terms of when we'll vaccinate kids, I think that the authorization for 12 to 15 is imminent. 16 and above is already authorized, at least for the Pfizer vaccines, 18 and above for Moderna. But I think 12 to 15 is probably imminent based on the statements that FDA has made publicly. So we'll be able to vaccinate 12 and above. As I mentioned before, there's 17 million kids aged 12 to 15. I think we'll pick up 5 million of them right away, maybe another 5 million by the end of the summer, a few more before school. In terms of below 12, FDA typically looks at kids 12 and above from a vaccine standpoint as little adults. They think that the experience in the adult population is a good proxy for how a vaccine is going to behave in children. Children get a more robust reaction, so sometimes you see more vaccine-related side effects, and you also see better antibody production. But 12 and above, you generally don't see something in the kids that's too much out of proportion to what you're going to see in a 25-year-old, let's say. So you can use the data from 18 to 25 as a proxy generally. Below 12, FDA views a child below 12 as a different human being whose immune system is very different, and they're going to behave differently to a vaccine. And what you want there is you want the lowest possible dose that's going to induce an appropriate immune response. So what the companies are doing is what's called dose de-escalation studies. They're studying successively lower doses in the 12 and below population to find a dose that is as low as you can go and still induce a level of antibody response that you know is going to be protective. Those studies are underway. I think in a best case scenario, you would have enough data from one formulation to maybe authorize that late winter 2021. I think that's an optimistic scenario. Might be more likely it slips into 2022. I would not expect a vaccine for 12 and below to be available in time for the start of this school year. Certainly, I think it's something that could become available at some point later in the winter.
So what do you advise pregnant women?
Get the vaccine. I mean, that's the advice from CDC. I think at least get the first dose. I mean, if you're worried about the reaction to the second dose, you can always get the second dose postpartum. A young woman should get a pretty robust immune response from a single dose of the vaccine. What we see is in the younger population, 50 and below, the first dose of the mRNA vaccines at least induce a pretty robust immune response. So you're going to get a level of protection. What we don't know is how durable that is. I think the second dose is still very important, even in a younger person, to preserve the durability of the effect from the vaccine. But if you're a young woman who's pregnant, you get one dose of the vaccine, you're going to get an antibody response. You'll transfer those antibodies to the baby, and the baby will be born with some level of immunity against COVID. That's really what you're trying to achieve, I think. I mean, you want to protect the mom, but you want to protect the baby too. And the most effective way to protect the baby is to protect the mom, and the mom will transfer antibodies. Because we've seen, if you look at the data, people talk about COVID being a more benign illness in children, and that's true. We don't, thankfully, this is not affecting children like it is against older adults. The exception is young babies. You do see neonates being severely affected by COVID. So you want to be careful with a young child, and if you can induce some immune protection through vaccinating the mom, that's an optimal approach.
So people who just see this on the internet and get misinformation worry that an mRNA vaccine is going to play with the genetics of their baby who's forming and developing new cells all the time. So can you just calm people down about why an mRNA vaccine isn't going to be dangerous to a fetus?
Yeah, I mean, so let's unpack what you're doing with an mRNA vaccine. You're taking a genomic sequence of RNA, of mRNA, and with the vaccine, you're basically encasing it in some lipids, some fatty substance. And the sequence that you're using is a sequence that codes for a very specific region on the coronavirus, that's spike protein. And you're injected in person. What happens is the mRNA basically unfolds, your cells take it up, and they start churning out the spike protein. So they read the mRNA, and they inadvertently, stupidly, start saying, wow, this is a piece of genetic material that I should transcribe and turn it into a protein. And they start making protein. And then all of a sudden, your body realizes that wasn't such a good idea. Maybe I should develop some antibodies to attack that protein that I just made. And so the virtue of it is that you're using the body as the manufacturing plant for the protein. Traditionally with vaccines, what we deliver is the protein. So the flu vaccine is protein cleaved off the surface of the flu. We grow a lot of flu in eggs, mind you, and then we deactivate the flu and use the deactivated flu or its proteins as the vaccine. Here, instead of delivering the proteins, you're delivering the genetic material that codes for the protein. So one of two things is going to happen. Either the genetic material is going to get turned into the protein, or it's going to get destroyed right away. And the reason why you actually get an immune response from these vaccines, and the reason immediately, like your arm hurts that night, and the reason why the vaccines seem to be really effective is because the mRNA itself is immunogenic. By just delivering mRNA into someone, you're tickling the immune system, as the scientists have said, because the immune system saying, mRNA, that doesn't look so good, maybe it shouldn't be there. So it starts to destroy it. It doesn't destroy it quickly enough, so some of it gets transcribed into proteins, but it's either going to get destroyed by the immune system or it's going to get turned into proteins. So the idea that it's going to linger around and get incorporated into your cells and become part of your genome, it's not going to happen. There's no plausible scientific thesis under which that could happen. And we've been working with these mRNA vaccines, as you know, for 2 or 3 decades. I mean, this is not a new platform. There were at least 20 products in development across multiple different drug companies using mRNA for other vaccines that were being produced or for treatments for cancer. In fact, the reason why Pfizer was able to pivot into the COVID vaccine was they had a program underway where they were developing an mRNA vaccine for influenza. And so they had a lot of that work already done. They were able to leverage it.
Okay. So we have some questions that we've received ahead of time from people who are in the audience now. And one of them, which is, I think, particularly salient to the Mount Sinai community, because we take care of a lot of very sick people, is what do we do for immunocompromised patients? Are they going to have the same response to the vaccine? Should they take a vaccine? How do we protect people who are on drugs that compromise their immune system?
Yeah, so there was a study about 3 weeks ago, I think it was published in JAMA, that looked at people who were immunocompromised on different immunosuppressants. Post-transplant patients was a very big cohort and showed, pretty significant degradation in the protection offered by vaccines in that patient population. One of the drugs that seemed to be most impactful at reducing vaccine effectiveness were people who are on high-dose chronic steroids. And so, I think that that's still a very vulnerable population, and people who are immunocompromised when COVID is high prevalence are going to need to be careful in terms of what they do and take added precautions. When I was going through chemotherapy, I didn't go out. I didn't go to movies. It was the wintertime. It was just flu season, but I was worried about catching flu or another respiratory viruses. So I think people still need to be careful. The good news, if there is good news, is that the antibody drugs should still be fully protective even in that patient population. And so, you could see a situation where you use the antibody drugs prophylactically. There's now data looking at the value of those drugs prophylactically, and they look quite good. So if you're a physician taking care of a patient who is vulnerable and severely immunocompromised, I think you'll see some of those doctors potentially using the antibody drugs, either eventually, hopefully on label, but maybe even off label right now, and dosing patients with the antibody drugs. That should afford a month or two of protection. Those drugs probably don't start to degrade until after a month. And so you get at least a month of protection, maybe 2 months post-infusion of an antibody drug. And what you're doing in that case is you're basically taking the antibodies that someone would have produced from vaccination, but they're not going to produce a very robust antibody response because they're immunocompromised. And you're basically giving them the antibodies in a bottle. And that's the treatment that President Trump received from Regeneron. And then hopefully by the fall, we'll also have some small molecule inhibitors of viral replication. There's drugs in development, including one by Pfizer. There's Merck has a very promising looking drug. So if we can develop sort of a Tamiflu-like drug for coronavirus, that's going to be a real game changer.
Yeah, that would be. You want to just elaborate on that? What do you see on the horizon, and how long will it take for that to get approved? How do those drugs work? Can we feel optimistic about Tamiflu for coronavirus?
I think we can be optimistic about it. I mean, it's hard to say. So, Pfizer has phase 1 data. Merck has a phase 2 data. The studies have looked promising. I think the top line message is that this is a very druggable target. The coronavirus is not HIV. This is not a virus that, replicates through very complicated machinery where it's going to evade our ability to drug it. We should be able to drug this target. The mechanisms that it uses to replicate are mechanisms that we've drugged before in other contexts. The Pfizer drug is a protease inhibitor. It's a sort of platform that we've worked with a lot. You always worry that these drugs are going to have off-target effects, and so you'll have side effects associated with them. So our potential to come up with a drug that's so clean, so non-toxic that you can just use it widely on an outpatient basis, that's always difficult. But our ability to come up with a drug that could be used in patients who are indicated for, maybe patients who are more vulnerable to the virus or becoming more sick, I think we're going to be able to do that. And hopefully, the profile of these products is such that they can be used on a widespread outpatient basis. So far in the clinical trials, they look pretty clean. They look like they could be molecules that could be used widely, but you don't really know until you get into larger patient populations in more pivotal studies and big phase 3 studies.
So let's talk about long haulers. I mean, what we have been really impressed with is the severity of symptoms that are sometimes very, very persistent. Can you give us your thoughts on percentage of people who wind up with some kind of persistent symptoms? And is there any way that we can start treating those people? Is this going to be something that will be a burden for the rest of their lives?
Yeah, I mean, I don't have great insight into this beyond what's been published, and what's been published is I don't want to say speculative, but a lot of uncertainty. I think that we haven't fully teased apart people who have symptoms related to protracted illness and the direct effects of the virus on the body and organ systems, and people who seem to have some post-viral autoimmune phenomena that we don't fully understand. In terms of treatment, there's data now showing that people who have some of these sort of post-viral types of symptoms, these autoimmune kinds of symptoms, seem to derive benefit from being vaccinated. That it's possible. You can sort of postulate reasons why that could be the case, by why re-challenging them with the protein could help sort of intervene in some of those autoimmune processes, but we don't know for sure if that's going to be the case. So right now, I think the bottom line is we don't have great information around this.
We're seeing a lot of them, a lot of long haulers. So let's go back to the school question. When should schools reopen? What are your thoughts on this? This is such a controversial area. And if we should have a resurgence and we're talking September, how does the community make a decision about whether schools should reopen or not?
Look, I think schools should be open in the fall. I think schools should adopt mitigation steps. I think they're going to reopen in the fall with mitigation in place. You're going to see kids, mask requirements. Look, some states are not going to do it. This has become a political issue in a lot of states. But I think the right approach is that schools aren't safe. They can be made more safe. And you've seen schools open successfully and be able to control outbreaks. My school district's been open pretty much through the winter. And we have cases. Every day cases get reported, although there haven't been cases reported this week, thankfully. But we've prevented large outbreaks that we're aware of in the school setting. And most of the cases that have been identified, my understanding is they're cases that were generated in household, and the kids brought it into school. It wasn't outbreaks in the school setting. But what are we doing? We've de-densified the classes. For a while, they were running morning and afternoon sessions. So 50% of kids were in a class at any one time. They've spaced people out. They've improved the HVAC system. They've required masks. Everyone has to wear masks. The teachers are now all vaccinated. So I think there's things you can do to make the school a safer environment. And if there's a risk that we're going to take societally in a place where we're going to be leaning forward, this is it. The big debate in the fall is going to be, what do you do with vaccination in kids? You're going to be able to, so the places where you've seen the most outbreaks in the school setting are high schools. They're less compliant with the masks. So it's harder to de-densify a high school. So you're going to have a vaccine where you can fully vaccinate your high school population. Our local district's going to require that. Right now, when I talk to governors on a bipartisan basis, they say that they don't feel they can mandate vaccines in the schools. They're very reluctant to do that. So I think this is going to be something that plays out at a local level. You're going to see local school boards and parents debate this at a local level. And there will be districts that mandate vaccination for high schools, and there'll be a lot that don't, at least at the start of the year. And we'll see how it goes. But I suspect if we start seeing outbreaks in the schools, there's going to be a lot of pressure to require vaccination. The pediatricians are going to probably be pushing vaccination in kids. I mean, assuming the data continues to support the safety and effectiveness in that population, you're hearing a lot of talk from the pediatric groups that they're going to try hard to coax parents to bring kids in to be vaccinated. You see some schools having vaccination drives at the school. And so that's going to facilitate more vaccination. But we will be able to get at least the high school age population vaccinated. And that's probably most at risk. And we'll be able to introduce it into middle school as well.
Good. So, when we were talking about booster shots, we were talking about antibody levels. But some of our immunologists tell us that you really don't need to know how high or low your antibody levels are, just that they are adequate. Can you just tell us your view? Is that true? Is it better to be high or low? Or is there a lot more to the immune system than just your antibody levels? And people shouldn't get crazed about what their level is.
Yeah, there's a lot more to the immune system than just the antibody levels, and people shouldn't get crazed about what their level is. And second of all, the tests that you're using to measure your antibody levels aren't accurate in measuring antibody response post-vaccination. Some of them don't detect. Some of them are detecting antibodies to the nucleocapsid protein. So they're not even picking up spike protein antibodies. My mom called me after vaccination. She said, I had an antibody test and it showed I had no antibodies. What's going on? And it was probably it was the wrong test. She was getting the wrong assay. So there's the belief is that there's a threshold below which you're going to lose protection. But above which, and it's a low threshold. I mean, the vaccines are inducing an antibody response well in excess of that. What we're seeing in the data, when you look at the data, is that even lower antibody levels, much lower than where you sort of start out when you're vaccinated, we're not seeing a degradation in protection. So it's not linear. It's not like as your antibody level goes down, your protection goes down. It's more binary. As your antibody level goes down, you're fine. And then all of a sudden it gets to a level, and then below that, you start losing protection. And the level at which you start losing protection is actually quite low to where you start out. So you can have a lot of degradation. That's why the vaccines look like they're really effective, even 4 months out, 6 months out, because you haven't fallen below that threshold yet. And so, I remember sitting in a room with a bunch of scientists, vaccine scientists, and I looked at the data. I'm like, is this just like a really wimpy virus? Is that what's going on here? It doesn't take a lot of antibodies to protect against it. And they said, yeah, that may be what's going on, that, you don't need a lot of antibodies to afford protection against it. Even a little bit's going to do it. But there is a threshold below which you're going to lose protection. And that's why, you talk about potentially the need for boosters. You're going to want to maintain people below that threshold. But
okay, so now we're getting some questions from the audience, and some of these are very personal, but I think we should answer them. This is an individual who's had one shot of Pfizer, and then 10 days later, they got COVID. Then they were given monoclonal antibodies. It's now 3 months later. Should I start taking Pfizer shots again? What do we tell somebody like this?
Yeah, the recommendation is there's after people get the antibodies, there is a period of time which they're recommended not to get vaccinated. It's a contraindication of vaccination. I think 3 months is outside that window if I remember the data correctly. And the recommendation around vaccination is that if you're infected with COVID, you should wait until full resolution of the symptoms related to COVID before you get vaccinated. And so a person like that sounds like they're outside the window, which they would wait and they can go get the second dose of the vaccine. And chances are they're going to have a pretty good immune protection between vaccination and prior infection. The antibodies will no longer be protective. They're out of your system by now.
So let's look back on what we've learned for the last 14, 15 months. What we know at the beginning here is that we weren't as adequately prepared as we'd like to have been. What are the lessons learned? How do we prepare better when it's not COVID, but it could be a SARS and Ebola, but that is just as going to be this contagious and perhaps just as lethal, but it's a completely new virus. Yeah, what did we learn? How do we do better next time?
I mean, it's a big question. I'll try to touch on a couple of things. I mean, one of the big failings in how we responded to this is that we were using a flu-based approach. We thought this would behave like flu. And so we underestimated the value of diagnostic tests, because in a flu pandemic, diagnosing people isn't as important. The incubation period is very short. You're not going to use case-based interventions to try to prevent spread. But in a virus with a longer incubation period like coronavirus, where a lot of this spreads through asymptomatic spread, getting people diagnosed becomes really important. So we didn't invest in a diagnostic test we didn't start doing it until late February, March. We should have been doing that in January, because we just didn't think it was going to be important. And literally people were saying in the government, we don't need a diagnostic test. It's not that important. We underestimated how much of this was spread through aerosolization. We overestimated the role of fomites because we didn't appreciate all the asymptomatic spreads. So we were seeing chains of transmission that we couldn't explain. And public health officials were saying, well, it must be from a contaminated surface because there was no introduction of the virus into that setting. Well, there actually was introduction of the virus into that setting. It was an asymptomatic individual who was maximally symptomatic, because you're maximally symptomatic probably 24 hours before symptom onset. And they spread it in an aerosolized pattern in a closed, confined space. And it was a super spreading event, but we didn't appreciate that because flu doesn't spread that way. Flu spreads from one person to two people. It doesn't spread from one person to 30. So we were sort of stuck in this flu paradigm, and we're trying to use this flu playbook that we had developed against pandemics, against coronavirus, without appreciating how the different characteristics of this virus would make that playbook really irrelevant. We also didn't have the sort of warm base that we thought we would have. We had invested in vaccine manufacturing capacity domestically, but it wasn't sufficient. We didn't have the ability to scale production of the antibodies. We didn't have excess capacity to make antibody drugs. We didn't have the ability to scale diagnostic testing. The reference labs like LabCorp and Quest didn't have the capacity to bring online tens of thousands of additional tests a day. We didn't have that's the sort of warm base of scalable capacity that we thought we would have. We ran out of commodity components like nasal swabs and plastic tips for pipettes because we didn't have domestic manufacturing of those, and never anticipated that in a global pandemic there'd be a global run on those supplies. I mean, we should have known it, but we didn't think about it. South Korea had stockpiled those things. They literally had swabs and reagents and pipette tips sitting in their stockpile because after their experience with MERS, they recognized that was going to become a strategic priority. We didn't learn that lesson. We never learned that lesson. I think the other point I'd make is that we're going to need to look at public health as a matter of national security in the future. We never looked at it through that lens. And that means a whole bunch of things. But one of the things it means is that, how do we prevent the next pandemic? Well, we're going to need to know about an outbreak in the future. And we've always relied on, public health, international treaties, international health regulations, and working through the WHO and requiring countries to raise their hand and report when they have an outbreak. It doesn't work. It didn't work in SARS-1. We strengthened international conventions after that. It didn't work here. China still hasn't shared the source strains. If anything, we've now taught nations that if you're host to an outbreak or a new variant, and you raise your hand and tell the world, first thing's going to happen is we're going to shut down trade and travel to you. So if anything, we've conditioned the wrong behaviors. So I think we're going to need to get our clandestine services more engaged in the public health mission. And that's always been an anathema in the past. They've been operated very separately, but we're going to need to do it here. We're going to need to change our mindset around national security implications, because if anything, COVID's proven that a respiratory pathogen is an asymmetric risk to the United States. This hurt us a lot more than it hurt a lot of other nations. And so we can't allow ourselves to be this vulnerable. And final point I'll make is we could have, even if you sort of discount entirely the belief that this could have emanated from a lab, and you believe this just emanated fully from nature, we now know, as a matter of fact, that this was circulating. The first cases were identified in December. Wuhan was having an unusually bad flu season in November. It might have been COVID entering circulation for the first time. If the first cases were diagnosed in December, it certainly started to enter circulation in November. We now know publicly that multiple samples of this virus were sent off for sequencing to BGI and Visions Medical's genomics companies in Wuhan starting in mid-December. And that's what we know. That's all reported public information. So it could be that there's even earlier samples that were sent. Those are soft targets. That information could have been gleaned, and we could have known about this much earlier than it appears that we did.
Well, we've unfortunately run out of time. So I want to thank you. My warmest regards. You've been very, very helpful, giving us powerful insights around what the future holds and what we should have done in the past. I also have to reiterate that it's with the support of our donors and friends that Mount Sinai can continue to lead in this way and do groundbreaking research and patient care. We really have been at the forefront here. It was our work that helped indicate that steroids were useful, that anticoagulants were useful, and that doesn't happen without the support of our donors. We're only as strong as our community, and we're fortunate to have such generous and dedicated people as the ones who are listening in today. So to all of you who've joined us today, thank you for being part of this discussion, and thank you for all you do for Mount Sinai. Have a good rest of the day.